The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's great to see you. Another Tuesday morning and another podcast.
Yes, it's another podcast, another Tuesday. We have another wonderful guest today, Dr. Mehra. And the topic of discussion for today is going to be boutique pediatric endocrinology as a fee-for-service model. Take it away.
Dr. Mehra is a physician executive speaker, champion of technology use in healthcare with comprehensive knowledge of managing complex disease, utilization management, healthcare IT, healthcare marketing, health and wellness, and telehealth. Her leadership experience includes a large multi-specialty group close to my house at Innova Fairfax Children's Hospital. And now she's the CEO of a boutique pediatric endocrinology practice. Welcome to the podcast. It's a pleasure to have you.
Thank you so much for having me.
We always start out, Dr. Mehra, by asking our guests, why did you become a pediatrician?
So I became a pediatrician because I really love taking care of children. I feel like children keep me young. They generally do get better. And I think we have a large influence on the overall health and well-being of children that we don't have with adults. Adult disease usually or adult habits are well ingrained. And I really wanted to get into pediatrics to help make a difference from the beginning. So I still love it. I love seeing children's faces. I love seeing the excitement on their faces from a very early age for little things. And I feel like it just really makes my day when I see them.
Wow. And then you had a very interesting trajectory from medical school. You went to UVA, which UVA, for people who haven't been there, is like an idyllic scene. The rolling hills, the buildings. It's a beautiful campus. And you moved from there to the middle of Chicago at Rush, and then went to Iowa for your endocrine fellowship. But also in your career, you were the leader of a very nice pediatric endocrinology group at Innova Fairfax Children's, and then transitioned to Anthem, which is our biggest insurance company in the state of Virginia. I think they have at least 40% of the insured market. I'm not sure what they have on the Medicaid side. Why did you go to be a medical director at Anthem, and what was that job about?
Yes, to give you some insight, a little bit on my background, I was actually born in Kabul, Afghanistan. So I came to the U.S. when I was 5 as an immigrant. And I grew up in Fairfax County, but I grew up on free and reduced lunch. I grew up with my family members, a lot of my extended family, who didn't really understand the healthcare system at all, didn't understand a lot about what it was like to go to the hospital, to go to a clinic in the United States. They hadn't really had that. And so I grew up in understanding really the Medicaid population, right? And when I went to Anthem, I was hired as a medical director for the DC Medicaid population. A lot of the reason that I wanted to go into pediatrics in general or medicine was really to educate people about their health and really help them understand what it meant to everyday choices that you make, how that affects your health and your goals, and also to teach them about healthcare, their healthcare and healthcare goals. And so I was hired really for the DC Medicaid population to look at chronic disease, in particular diabetes, because I'm an endocrinologist. Diabetes is rampant in the African-American population and Hispanic population, and in the Indian population, which I'm part of that. And really to help educate families and children really on that disease process. And so that's why I went in there and to really focus on policy changes. Could we change policies? And I did. I changed some policies at Anthem related to diabetes, related to continuous glucose monitors, really educating these people on why we use certain drugs, why we use certain devices in healthcare. And I enjoyed it when I was there.
And so you were basically an internal advocate.
Correct. Yes.
That's what you were doing.
Yes.
And why is, and when you say diabetes, are you referring to type 2 diabetes mostly? Or
It was both type 1 and type 2.
Type 2.
I'll give you an example. When I started at Anthem, they were not approving continuous glucose monitors for patients with diabetes with type 1 unless they had certain strict criteria. You have to have 4 blood sugars that are below 70. It was really ridiculous criteria. And I really advocated to change that because I said, do you really want these kids or these adults to have seizures before you're going to approve a continuous glucose monitor for them? Because you're dictating that they have to have low blood sugars and hypoglycemia. So some of these things on the policies are made by people who are non-medical and non-specialists. And I think that was my goal when I was there, to really help educate people who didn't know about the disease processes that I was treating.
What kind of people make these policies if they're not doctors?
A lot of them are doctors. I would say they're not endocrinologists per se, right? Who are like seeing these patients day to day. A lot of things that you can get from articles, research articles, journal articles. But in clinical practice, it's different, right? If I have a patient who comes in who needs something or needs a drug, some of it is like the art of medicine, right? Like really advocating for that. And so there are physicians who are behind the scenes doing this work and doing good work, actually. But they don't know the ins and outs about what we do in clinical practice.
The reason I asked is, what is it, a genetic, or is it genetic plus diet that makes type 2 diabetes so prevalent in the African American community, the Indian community, and the Latino community?
Oh, I think it's genetics and it's environment. In the Indian population alone, it's 1 in 4. So 25% of, in a family, 1 person in 4 will have diabetes, type 2 diabetes. And a lot of it is genetic. And then the diet doesn't help at all.
And then what kind of policies because the Medicaid population is a very difficult population. And people get mad at me when I say this, but unfortunately, you get to be making less than $30,000 a year when you don't have a lot of executive functioning. There's a lot of other things that go into it, but if I'm on a plane and they cancel my next leg of my flight, I have a lot of executive functioning because I've been trained to have executive function. I also have a good credit card, but I would look for a rental car, or I would call and say, I'm not going to make it to the meeting. I have this ability to problem solve. The people making less than $30,000 a year don't have the credit card, and they miss the bus, and they don't make any step to let anybody know they're going to miss the appointment. They just don't show up. And so what policies did Anthem have success in trying to educate this high-risk population about changing their lifestyles to improve?
Yeah, they do a lot of good work. And I know insurance companies get a lot of negative feedback, but they do have a lot of case managers who reach out to the patients, and they have transportation cards that they often give patients to get to their appointments. And they do have a lot of social resources that actually, as a physician, when I was practicing, I did not even know what resources were available, right? Because the insurance companies really get a negative vibe. And they have an incentive also to get people to go to the doctor, to prevent hospitalizations. They do have monetary incentive to do that. A lot of it, though, is just that population itself just doesn't know what's available to them, doesn't know. They're trying to just make it through their day, get their money, live, get enough food for their families. Some of it is as basic as where they live. There's not a lot of fresh fruits and vegetables, and there's Dunkin' Donuts down the street that they can feed their whole family breakfast for. A lot of education that we were doing just regards to some of that also.
Yeah. It's more difficult to make your own meal from scratch than to run over to McDonald's and get a burger and fries at the kids.
Correct.
So it's a big ask. In particular, I have a patient in clinic. She's under 35. She has 7 kids, doesn't have a car, doesn't have a job. I can't imagine. I can't imagine how you survive that. I can't imagine having 7 kids. And then you transition from a very academic place at Innova now to a very personalized care model. What do you miss about, and Innova is not the big university, it's in between the big university and the personalized care. But what do you miss from the big health system now that you're not part of it?
Yeah, I will say when I left clinical practice, I actually never thought I would go back. And What I miss is the people that were there. I miss my colleagues. I had a very hard time leaving, but I always felt like I wanted to make a bigger impact or make a bigger difference than that one-on-one. That's why I left. I wanted to make a bigger impact. And I thought that the DC Medicaid population or that Anthem position would help me with that. But then I missed clinical practice. Like when I left, I was like, oh, I miss the day-to-day interaction with my patients. And I definitely miss my colleagues. I miss the nursing staff. But what was missing for me was that personalized attention that I could not give in a large healthcare system. I cannot educate patients on diabetes in 10 minutes. And that's really all I had. And I thought about, do I want to go back because I missed patient care? And I was the medical director of the practice. So I had some say in how we conducted our practice and how we saw our patients, but not much. A lot of it was based on our RVU goals. And it always boils down to money is what I learned. Even in the health insurance field and our medical practice, it always boils down to money. And I just didn't feel like I was providing good quality care. I didn't feel like my patients got the best health care that they could in the constraints that I was placed in. That's the reality of how it was.
So isn't like diabetes education something that's supposed to be provided by a diabetic educator, not the physician?
That's a really good question. Yes. And we had a lot of diabetes educators, okay? But they're also limited by how much time they have to spend, right? And we had a lot of phone calls overnight, a lot of phone calls about my blood sugar is this high, what do I do? And diabetes is a very difficult disease. It's a very difficult disease for parents to manage. It's a very difficult disease for children to manage. They're in school. They are going to birthday parties. They are going to the movies. They are driving. There's so many factors. And the reality is we just don't have all that time as healthcare providers to provide it. Even a diabetes educator. Yes, we provide the initial care. We actually did a boot camp for them when they first, started. It was like 6 weeks of intensive care. But it's a lifelong process to learn some of this. Yeah.
You think that the education is accepted easier by a patient if a physician such as you tells them about it, or some person that just knows about diabetes and tells them what to do?
I think overall, and I can't speak for every patient, there are patients who don't listen to physicians at all and do their own research and find some of those things. There is a lot of mistrust in medicine and in the medical community overall. And I will tell you, I have learned things from my patients. I have learned a lot of things that when I was in fellowship, I was trained to never tell a patient with diabetes, especially a pediatric patient, that they should restrict carbohydrates because it affected their growth and affected their development. And that's what I always used to say to my patients. And then I had a patient at Inova who the parents were highly educated professors, and they brought their kid in, two-year-old eating keto diet, basically. And his blood sugars were super stable. And I used to say, he's not going to grow well. Like, you need to, get some carbs. And guess what? He grew fine. He grew perfectly. And his blood sugars were stable. And his A1C was less than 6%. And so I feel like we're learning, and we're learning a lot of this as we go. So I don't feel like I'm all knowing. I think a lot of it is you live with the disease and you learn certain things that as a physician, I don't have diabetes. I don't know some of those nuances. So I think we're learning a lot of things. But I think for me, I just felt like as a physician, all I was doing was telling people to increase or decrease their insulin. And that's all I had time to do. And so I could refer them to the diabetes educator, and they were great diabetes educators, and they spent a lot of time with them. But then the next time they came to see me, again, all I was doing was increasing and decreasing their insulin. And that wasn't, for me, it just wasn't fulfilling enough.
Yeah. I always, and it's hard to stay humble, but when you have a patient in the exam room was the parents are managing a chronic disease, they know 10 times more about that disease than I could ever learn. They know. They're a competent parent, right? There's all kinds of parents, but 80% of the parents, whatever the disease is, they know what works and what doesn't work. And what the textbook says or the specialist says, they go, no, that doesn't work for my kid. And as long as they're getting good outcomes, you just have to say, okay, I understand. I'm here. Things change. But that's a very important lesson for young physicians to learn. Patients parents taking care of children with chronic disease do become the expert. They learn a lot more about that disease than we can ever learn by practicing or reading. I personally would miss, because I find this when you're a part of of a small office, is having that psychologist, having that nurse educator, having a nutritionist available. That would be, I think, very helpful, especially when you're talking about obesity and type 2 diabetes. But I hear what you're saying, I think what you're saying is 10-minute interactions where you just adjust the medication do not serve the family or the physician well. And that's all there's room for in a big organization. So it's a very interesting journey. You came here as an immigrant on Medicaid, not knowing how to navigate the health system. And now you're in a boutique endocrinology practice where people pay cash to see you. And what is the advantage of being able, and maybe you should explain how the business model works, but they're basically paying for 45 minutes of your time when they come see you.
They're paying for an hour. And I think the reality is that I have learned a lot from the business side of medicine. I worked at Anthem. I ended up getting my MBA because, like I told you, I'd never wanted to go back to clinical practice. That wasn't my goal, to go back to clinical practice. It wasn't my goal when I left Inova to ever start my own practice. I never had that goal. I got my MBA because I was sitting around the table with finance people in the health insurance field, with CEOs and executives who were basically talking about dollars and cents all the time, right? Cost savings. And I didn't understand anything that they were talking about half the time. And I thought, I need to learn a lot of the business of medicine and what goes behind it. And I was very interested in policy and policy changes. In fact, I was offered a position to be the director of Fairfax County's the health department. And I was really interested in going that route. And so I ended up getting my MBA to learn about that and learn about policies and the business side of medicine. And while I was in the program for my MBA program, there was a program with 50 other physicians who were getting their MBAs. It was a physician executive MBA program. And while I was in that program, every physician came to me and said, why are you in health insurance? Like, you need to have your own practice because there's such a shortage of pediatric endocrinologists. We can't get people in to see you. And when I was at Inova, I was the telemedicine director. I was trying to start a telemedicine practice there, but we were constrained by the fact that health insurance companies didn't pay at that time. This was before COVID, did not pay for telehealth. It was very restrictive how they paid. I really wanted to provide diabetes care telehealth. It's just so much more convenient for the patients. They're coming every 3 months. Why do they have to come into our office and drive long distances just for me to adjust their insulin? I thought it was ridiculous. Like, they would come every 3 months, sometimes every 6 weeks. But I was constrained because we wouldn't get paid for it. So the organization said, you cannot do telehealth. They have to come in the office. Half the time, like you said, they would miss the appointment because they didn't have transportation. They didn't want to miss work. They didn't want to miss school. And so while I was in this physician executive MBA program, my mentors there were like, why don't you just build a telehealth practice? Like, you could charge cash. You don't have to worry about health insurance. And so I was like, are you crazy? That's never going to work. And I went through this whole process. I did market research. I had to do this project to graduate from my MBA program. And that's why I did it. And in the end, my mentors were like, why don't you just launch it and see what happens? Just see what happens. And that was my goal, was to provide care in a more convenient fashion without the constraints of the health insurance world, because I have to just check off so many boxes to get reimbursed. So I don't know if that answered your question or not.
Yes, but the value proposition, and please correct me where I'm wrong, but I'm assuming that because there's buckets, right? So most of our listeners are physicians, so they know if you're a Medicaid patient, you pay for nothing. That's it. But the middle class are burdened by high deductibles, $5,000 a pop. And I have no idea what Inova has a contract for 99214s, but what's a 99214 Medicare, George? 150?
I'll tell you in a second. It's 150.
About 150. So they're
Yeah.
probably charging for a 99214 visit $300. That's what they're getting. That's what they charge Anthem, and then I have to pay Innova $300 to bring my kid to see you every 3 months. And if I could pay, and I get 10 minutes of your time, but for that population, I'm still going to pay you the 300, whatever, 350, 400, whatever it is, but around there. But now I'm going to get your attention for 45 minutes to an hour, and I might be able to do it through text, or I might be able to do it on a phone call, or I might be able to do it through telemedicine, or you might say, no, I really need to see what's going on with the pump because I'm worried about the pump not functioning. Bring the kid in the pump in so I can look at it.
Correct.
It'll take 10 minutes, but I want to look at it. So as a customer, I'd rather have the hour and the flexibility than the 10-minute and be part of a very efficient but ineffective system.
Yeah.
And I'm still paying the same amount.
Yeah. And I will tell you that most of my patients, I do the first visit, but then they're at a membership and actually likely going to decrease my membership rates a little bit because I want them to have more access. But most of my patients we provide a super bill, we bill for them, this bill gets submitted to their insurance company, they get reimbursed. So some insurance companies will reimburse them for other out-of-network benefits up to 75% of my fee, right? So they're actually paying less. And then they have
they go to their deductible first.
Goes to their deductible, exactly. But if they have a high deductible, they're going to pay that anyways, either way. But if not, then they get reimbursed for that. And so they actually like it for that reason, and they get more time. The other thing that I found at Innova, and I don't know how other physicians feel, but it's part of a large organization. I saw a lot of patients. I probably had a panel of like 2,000 patients or plus, more than I saw. I had no time to answer their messages between like their visits. So if they had a quick question about their lab or my blood sugar's high or my thyroid function, whatever, I had no time for that. And I had to tell them, you need to come in for an appointment. I don't have to do that now. I can just answer their questions, right? They can text me, they can email me, they can message to the portal. And I purposely don't want to take a large volume of patients because I want to provide more of a family-centered approach and smaller number of patients so that I can manage some of that because we all know time is just a limiting factor for all of us. So for me, and I do get these patients who have Medicaid or who don't have insurance, actually. I do get quite a few of those patients who don't get insurance and who don't have insurance. And whether they pay me or they pay the large healthcare system, that's their choice. But with me, they get that hour-long visit, they get communication. And those patients are the ones that I spend the most time educating about whatever disease they have because they don't get that time. If it was me at Innova, I wouldn't have that time to spend with them at all.
Yeah, I think I talk about that in order for the kids to be healthier, we need to get away from volume.
Mm-hmm.
Because physically and emotionally, you cannot see 20, 30 patients a day and do a good job. You just can't. And the more complicated the patient, the more time it takes, but it takes a toll on your thinking capacity and your emotional capacity. But no lawyer would meet with 30 clients unprepared in a day. At the most, they meet with 2 or 3 clients in a day because they prepare, they look at your case, they look at your contracts. By the time they call you, they're ready to have a discussion with you. They would never go into a courtroom unprepared and see what 30 cases they're going to defend today out of the blue like we do. All right, make the appointment, see what you're here for, see how I can get through it. And for healthcare in America to improve, we're going to have to limit volume so that the thinking specialties can actually take the time to be effective, not efficient, but effective. And in the long term, that should save money because people should have better outcomes. And that's basically what your value proposition is. You will be effective. You will have the time and the flexibility to take care of the patient well, not in a forced upon system of the insurance companies and the health systems to treat you in 10 minutes like another number and click on Epic and next. So it's a nice model. So what illnesses do you treat in this new boutique practice?
So I treat everything endocrinology. So my majority of my patients actually come to me for growth. So growth and short stature, probably, I would say number one. And then I'm obesity board certified also. So I treat a lot of pediatric obesity, weight management. I treat type 2 diabetes. I have type 1 diabetes in my practice, a lot of thyroid. So really it's a whole gamut, puberty issues. So I have a couple of patients with adrenal insufficiency. So it's really a whole host of pediatric endocrine disorders. I have a couple of patients who have panhypopituitarism. So interestingly, missed in a large healthcare system, missed diagnosis of panhypopituitarism. And it's not, I think that's what keeps us humble is really that would have been me 5 years ago, not having the time to look at like all these labs very closely to try to figure out these diagnoses. So I treat everything really.
And then what strategies have you found? Because now George's partner is obesity certified too.
Mm-hmm.
But because they're in the insurance business, they struggle to maintain the program because it's very time intensive to counsel these patients.
Yeah.
And what strategies do you find that work well for the obese pediatric patient, short of medications, which are not available if you have insurance in Virginia?
I actually have created my own course. So I have a course that I put together. It's about 45 modules with regards to, diet, exercise, lifestyle changes, recipes, those kinds of things. I have a monthly newsletter that comes out to all my patients with recipes that we talk about. We talk about healthy eating. I have an Instagram account that we do a lot of education there on portion sizes. And then I talk to them. And so my members come in once a month. I meet with them once a month, mandatory meeting. If they want to be on weight loss medications, we talk about those, what's available. My patients have been able to come off of medications. We use the medication sometimes as a tool to say, let's do this short term, see what happens, what you learn. A lot of them are learning that their portions were way too big. That's just what they learn, all of them. And once we start weaning them off the medication, they're able to maintain their weight loss because they have had exercise. We talk about building muscle, proteins. We talk about that almost every single visit. A lot of it is repetitive. I have a new machine that I just got, the Sika machine that measures their body fat and their muscle mass. So we do that for our weight loss patients to give them another tool to look at. But really, it's the frequent meeting. And again, I'm not limited by insurance at all. So I think for me, I have found great success in pediatric weight loss for that reason, because it is basically just me and a course that I have put together, okay? But it's frequent, over and over again. And sometimes it's weekly, like I'm meeting with them once a week. Like, how's it going? What do we need to do? You're having side effects. You are not able to control your portions. What can we do? And I have a new program that we're going to start probably in January with an exercise physiologist and a nutritionist that we're going to focus really intensely on the exercise piece of it. And it's not insurance-based.
So frequent touch points and frequent reminders seem
Correct.
to be the recurrent theme here.
Yeah.
And I think in the insurance world, they want you as a physician to say, you should do this and the other thing and be gone. One visit. Now, I was seeing that even with Dr. Riley's clinics. He sees them often and sees them for too long a period of time. But he does good outcomes. He has good outcomes. You know what the sad part of the whole process is? He used to be the top earner in the practice. Now he's at the bottom of the barrel. But there's other people to subsidize this. So we use it as a stepping stone for insurance negotiations to show them that we're actually doing something right, chronic care. And it helps us with enhancements on the other side.
Yeah, but it shouldn't be that way, right? Because the work that Jim's doing is valuable, very valuable. That's a childhood obesity, type 2 diabetes, and mental health are some of the most common illnesses now seen in the pediatric clinics every day. And it has a long-term effect on population health. And I'm not an endocrinologist, but reading the literature, type 2 diabetes and obesity is much more toxic in children than it is in adults. It progresses much more rapidly to the microvascular damage. And we, unfortunately, I keep saying this like a broken record, we have no Farmington studies. I don't know if putting a 12-year-old on GLP-1s makes a difference on cardiovascular outcomes 15 years from today. I don't know if a 12-year-old with a blood pressure 125/85, which is hypertensive for a 12-year-old, has better outcomes if I put them on a antihypertensive, an ACE inhibitor today. We don't know if somebody who has type 2 diabetes or pre-diabetic and is 12 and has an LDL of 130 would do better on a statin from a cardiovascular point of view 15 years from today. Seems to me that they would, but I have no evidence to base that on.
If we don't do things, we'll never know. If we don't try things, you'll never know.
There's a risk that it doesn't change the outcomes and it does harm their liver.
Yeah.
But you don't know. You can't use a medication that you haven't proven efficacy on. And so it's a very difficult, it's an area that we need to invest more in. But I don't know how we're going to do that. But I think to your point, you both have MBAs. They teach in business school that what gets measured improves.
Correct.
So if you want to improve your aerobic capacity or you want to improve your weight, it has to be measured and someone has to hold you accountable for that outcome.
Mm-hmm.
And if you create that cadence, good results. It's a business model. Come back. What are the metrics this week for your department? We said we're going to be at this. What actions are you going to take to get to that point? And that weekly touch makes a huge difference.
Yeah.
And then how has this business model improved or worsened your lifestyle, your balance between work and family and other enjoyable activities?
I will tell you that when I left Inova, I did not realize how burnt out I was until after I left. Like I told you, never wanted to go back to clinical medicine. I just felt like I wasn't doing a good job. I wasn't doing well with my patients. Actually, I felt very undervalued. I was told over and over again that I would never have a raise. Our salary would stay the same no matter how hard you work. It really doesn't matter. And I think my quality of life overall was fine at Inova. Like I was the medical director. I had control over my schedule. I had great staff, great physicians. I respected all of them. But I just felt very unfulfilled just with my day-to-day. And I didn't realize that until after I left. And I used to just think, well, I'm just a pediatric endocrinologist. I'm not going to be, why did I do this? Why did I pick this? It was like low-paying field, no respect from anybody. I don't do procedures. I really felt like I made a mistake, right? And then I left. And interestingly, Anthem was the place that gave me my confidence back. Like, I am a pediatric endocrinologist. Everybody used to be like asking me questions all the time and asking me to make policy changes. And what's your opinion on growth hormone? Does this kid really need it? And I was like, wow, they want my opinion. And then when I went to do the MBA program, it was even more, wow, you're a pediatric endocrinologist. We really need your specialty. And now I feel like from a fulfillment perspective, I feel like I picked a great specialty. Like I know a lot of parents don't know about some of these things. Pediatricians don't know. Internists don't know. I have a lot of knowledge under my belt. So from a fulfillment perspective, I feel like it's been great. Monetary-wise, it's like you're taking a smaller volume of patients. You have to take a hit somewhere. It's not like I'm making tons of money. I'm doing a lot of work on my own, a lot of things that I feel like this is not working for me. I need to change it, or the scheduling's not working, or the cost is not working. Something I have to change. So I feel like it's constantly learning new things. Constantly learning how to run a business is very different from just seeing patients. I think in the beginning, and I'm still in the beginning phases, I work a lot on the business. I work in the clinic. I work in the business. I am thinking about things all the time. I'm thinking about how to market, how to do my profit loss statements, reconcile things. Do I have money to hire somebody? So I think it is a lot of work. It's a lot of work. Professionally, I feel fulfilled, but it's not the work-life balance that I probably had before in a large group because it's just me and I'm running everything, essentially.
So it sounds like you became a doctorpreneur.
Yes, that's right.
Yeah, in private practice, old school private practice model.
Mm-hmm.
This is what we do.
Mm.
I think the systems tricked the physicians into giving up their practice by coming up to them and saying, "Doctor, why don't you do what you do best? Stay in the exam room and let us take care of the rest."
Mm-hmm.
And when they do that, they mess it up. And they make your life difficult. And they blame you for lack of reimbursement or lack of this, lack of everything is always your fault, doctor, because you're in the room.
Yeah.
When it's actually them. Inefficiencies, bureaucracies, and all of that stuff that comes with it.
Yeah. And now I feel like, why do we have so much staff at Inova? So much staff. It's crazy how much staff we had to do. I don't think we needed 5 MAs. Like, all of that comes out of my pocket right now if I have to hire an MA. But I agree with you. It's very interesting. And what I like about it is, though, if I don't like something, I don't have to go to 10 meetings to talk to 10 different people or 20 different people to make a decision. I just change it.
Yeah.
So I learned a lot about how to put my website up, like very basic things.
Yeah. Staff is not a bad idea as long as the staff functions and you get the patient in kindly, you get the patient done through the door, they do things for the doctor does his job, and you move on to the next one. And there's good quality. But what I found is when there's too much staff, less efficiency happens because the other one always thinks that the other one is doing it.
Yeah.
No accountability, no responsibility. And then the machine slows down.
Mm-hmm.
What happens often, in my experience, in these very large organizations is you have 3 people, whatever position, front desk, medical assistant, whatever it is, even physicians. And one of the 3 is not pulling their weight. So the answer is to hire a 4th person, not to address the person that is sitting talking to their family on the phone in the back and not bringing patients back. It is to hire a 4th person. And everybody's overwhelmed, so they hire a 5th person. And then they don't understand why they're not making money because you never hold anybody accountable. You never terminate anybody. You just adding in the bad apples don't get weeded out.
Yep.
That's a lot harder in a smaller company because you notice right away who's causing problems and you're like, I can't deal with it. I only have 3 employees. I can't have one that sits in the back all day. But the problem really is the business model of ram 30 patients through a pediatric endocrine clinic and work at the top of your license, which is a fallacy. Don't spend any time, and then you miss things right and left, even though you're trying to do the best you can, and the patient doesn't get the best outcomes because you didn't have time to think about it or talk to them about it. And somehow that's got to be changed. I don't know how. Maybe from having been at Anthem what their thinking is because they never really want to pay the primary care doctors a dime more. They're always like, nope. There's no
outcomes, right? Like it's always about outcomes. And I think, George, I think you hit the nail on the head too. Like you're just in a large organization and you have all these different people that are controlling things and it's always the physician's fault. But the reality is we don't have time to address some of those things. Like you don't have time to talk to somebody about how to lower their cholesterol rather than throwing them a cholesterol drug and being like, see you next time. I think it's very sad, the state of healthcare. I think it's very sad. It's very sad the way we have to practice. But there's a shortage. There's a shortage of all of us. There's a shortage of everybody. There's a shortage of pediatricians. People are leaving. And I think for me, it was really finding the love of medicine and my specialty again that this allowed me to have. Because I didn't even, when I was at Inova, I did not even want to go to a Pediatric Endocrine Society meeting. And I was like, I don't want to deal with this anymore. Like, I'm so sick of this. And now, I can't wait for the next meeting. I can't wait for the Obesity Society meetings. I can't wait to learn more information because I directly want to give that to my patients back. And so it's just a different style of practicing that I wish we could all practice the way we want to, practice the way we think will be effective.
Yeah. And I was going to ask you about the GLP-1s. When do you think about using them? Because you said something very interesting. You use them as a tool to help people start on their journey. And your experience is you can withdraw the medication and then they don't rebound, which is not what that's not what the adult studies are telling us.
But I find that in pediatrics, first of all, we do have data that shows that they're safe. We have data that shows we've been using them in endocrinology for a long time, right? We've been using them for diabetes. So I follow the guidelines. I don't use anything that is compounded ever in pediatric population, ever. But by the time people are coming to see me right now in my practice, okay, they've already gone to Ideal Clinic at Children's. They've gone to their pediatrician. They've gone to dietitians. They've hired trainers, okay, and they're not losing weight. And so by the time they come to see me, that is what they want. They want to be on the GLPs. And we have that, they're paying out of pocket, okay? And there's not a lot of people who are doing pediatric obesity, especially in this area. And so we have a good discussion about it, like risks, benefits. I use phentermine too for some of the patients, and there's good outcomes with phentermine, short-term and actually long-term use. And so we talk about that. I use metformin for my diabetics, PCOS patients, but really have a good discussion about what drugs are available and what are they willing to do. And I have found that both phentermine and GLP-1s really teach patients what their portions are. You can exercise. That's what I get all the time. Johnny exercises all the time, can't lose weight. That's because he's overeating, right? Overeating and over snacking. And food is available all the time. Like every birthday party, every school function, everything. Your own internal cues of the child are just not, you're not recognizing those internal cues that I'm full when there's food available all the time for you. And so what I found that the GLP-1s do is help with that process. Like, I am full, stop eating. And I tell them that when you are full, you're going to feel sick if you keep eating with this medication. They learn that over time. Some patients it's 3 months, some patients it's 6 months, some patients it's a year, but they all learn that I'm eating too much. If you eat fatty food and greasy food and you go to McDonald's and you are on a GLP-1, you're going to feel sick, right? And so it's a learned behavior that stop eating those foods because you're going to feel sick. And after 6 months or a year, you're off those medications because you've learned, like, that food just makes me feel sick if I eat it. And so I've told people, it's not great for me from a monetary perspective, but I've told them, you're gone. Like, you're done. You have met your goal and you've learned. You've learned how to eat. You've learned the types of food to eat. I also tell them, you're going to be constipated if you don't eat fruits and vegetables. When you're on this medication, start increasing your fruit and vegetable intakes. You're not constipated. And they do. And they do. And I've had people who used to eat McDonald's all the time, and they come to me in a year, and they're eating like chia seed pudding and like vegetables. And I think it is a great tool. It's not a lifelong medicine for a lot of my patients. First of all, they can't afford it for lifelong, right? And the federal government, the federal plans are planning on discontinuing coverage for some of these medications starting in January. So they have to learn. But how else are we going to teach them? Like, I can tell you everything, but sometimes they need a little bit of the medication to just give them some techniques to learn how to eat.
Because I'm all over the place. The AAP guidelines I find to be atrocious on this issue. But where do you start? Because if you use the guidelines that Medicaid in Virginia uses, you have to be like a BMI of almost 40 before they will approve a GLP-1.
It's I think it's over 95th percentile BMI. And so I've had them cover it. Medicaid is different, right? That's different. But
yeah.
The federal plans so far have been covering it. I've had great success with federal plans. Some people are paying nothing. Some people are paying $25 a month. And it's BMI over the 95th percentile, basically. Try diet and exercise. We're in a comprehensive nutrition program, which I have for them. And it's been approved. It's been approved. Actually, DC Medicaid has been approving this medication. $0 for them to pay. And then, but I mandate, I don't give them more than 1 month supply of the medication, no refills, because you have to come back to see me. You are not just on this drug and do whatever you want, and that's it. So you have to be on it. And I find that if they're losing a good percentage of body weight, the guidelines say stepwise increase their dose, right? These kids don't need a stepwise increase most of the time. A lot of times they can do well on the lowest dose because I don't want them losing 20 pounds in a month. That's ridiculous. We don't want to have that. So I think really close follow-up is really important for this. We do a lot of prior authorizations. We do prior authorizations for everybody. They don't cover it. They don't cover it and they don't get it, but they still are welcome to be on the weight loss program that we have. We try a different medication. So I think there's lots of different tools. And I think that's also being in this practice model, we can change things up or be resourceful in what we try.
Yeah. I don't know what the pediatric definition, I guess, is 95%. But I like that definition of 27.5 BMI plus one comorbidity. Like your BMI is 27.5 and you're hypertensive, or you have high cholesterol, or you have a very big belly. I like that as a cutoff much more than just 95%. Some kids are overweight, but it doesn't seem to bother their metabolic profile. It's just bizarre. Everything looks good.
It will over time. It will.
Inshallah.
And my goal, like I'm an endocrinologist, my goal is diabetes prevention. Like we need to prevent diabetes. It's going to be rampant in the next 10 years.
Already.
Yeah.
It's a big problem because pediatricians and internists don't know how to take care of type 2s or pre-diabetics. They don't know how to tell the difference between type 1 and type 2. But I found the cardiometabolic profile, are you talking about that's improved greatly in my patients, greatly. So when they lose the weight, yeah.
When they lose weight, yeah.
Oh, yeah. The lipids are normalizing, their blood pressure goes down. Yeah. And their depression improves. Yeah. So, and it happens over 2 or 3, you don't have to wait 15 years. So, yeah. So what are your thoughts on the future of pediatric endocrinology with the workforce shortages that we have and the current lack of payment and time for the work that you guys are doing?
I will tell you there is a movement for direct care for pediatric endocrinology. So I'm in a subgroup now, about 10 of us across the country who are doing direct care, pediatric endocrinology. There's more movement towards that. Unfortunately, I think in the large healthcare systems, you're going to be seeing more nurse practitioners in the field because there is a huge shortage of people going into the specialty, people who are in it right now going to be retiring soon. The pay is low for pediatric endocrinology overall. Somebody from Inova just left, also peds endocrine. So there's going to be a huge shortage. I don't know. I really don't know what the future looks like for our field in general. I'm trying to encourage more people to go into a field where they can have more time. And I would love to hire somebody who I could train in this business model, that they would be able to have flexibility with their lifestyle, flexibility with how they see their patients, and make a good income.
Yeah. Maybe
what I don't understand is why in the world can't the insurance industry just pay for services like hers? It's a simple model. They used to have the consultation codes back in the day. Their reimbursement used to be close to $300. And this is 15 years ago. They took them away in office consults and made everybody 99214s, threes. Why?
We're spending the money in the wrong bucket. Spend less than 5% of the dollars in healthcare and primary care. And primary care physicians are doing 50% of the visits.
Yeah.
If you pay the primary care physicians better and you lower the volume that we have to see, then I don't have to refer every pre-diabetic and every type 2 diabetic over to the peds endo clinic because I have time and I can develop those skills and I can learn and I can be a filter. I can send the kids that don't lose weight after I've done a 6-month intervention to the peds endo. And so they're seeing the most complicated, but the other ones that are already improving, I can take care of. I can take care of the type 2 diabetic in the clinic and only send the ones that I can't get to target. And so the system works better. But on the other hand, we have to pay the peds endo enough so that $400 for a consult. So they're seeing a consult, they can spend an hour with that patient and the system starts improving. But we're paying a lot for hip replacement, someone quoted $170,000 for hip.
How much?
$170,000.
No way. I thought it was like 30, 40.
Some hospitals are getting
Is
hundreds.
that with the facility and the operating room?
That's the facility fee, and then the doctor gets a different payment.
Oh,
Some of these breast surgeries are 70 grand for the health system. So compared to what is it, $65 that Medicaid's paying us for seeing a kid in the office, other people are getting paid the hospital is getting paid hundreds of thousands of dollars to do procedures. So that's where the problem is. We got to give some of that money back into the middle class so that they get the care they need and the outcomes improve. And there's no will to do that.
everybody's going to go into direct primary care, direct medical care, and there'll be doctors anywhere.
That's how Northern Virginia is. If you want an internal medicine doctor, bring your American Express card because it's a $3,000 concierge fee.
Mhm.
Well, you can't afford that. There's patient one. Patient first is an urgent care / primary care big clinic. You can go stand in line there and get your cholesterol medicines.
Fine.
But in Northern Virginia, if you don't, there's only concierge adult doctors left.
Yeah.
That's it. And it's $2,500 to $3,000 on top of your insurance.
Yeah. So what are your thoughts on this, Herb? Value-based care. It's going to be ridiculous. It's capitation. That's what it is.
I don't think it's capitation as how you think of capitation. It's just, this is a direct consumer business, which is different than capitation.
The direct-to-the-consumer business line is you have a membership fee per month, whatever it is, 100, 200, 300. They get paid every month, and then the doctor is on call and deals with all the things and does text messages, telemedicine, in person, does everything for you. In the capitation world, it was $30 way back 15 years ago, 20 years ago. Now it's 35, 40. Can't do it.
No, it's again a volume-driven business, not a quality. It's an efficient, but it doesn't have impact.
But it does work when it works.
Yeah, I know.
And there's a pandemic.
During COVID,
During COVID, I had a friend of mine that was mostly capitation. He had a lot of volume, and somebody was positive for COVID, so they shut down his office. And we were struggling to stay open and figure out how to see people. I could not comprehend why he would just quickly shut down his office.
Yeah.
You know what? And his answer was, we get paid anyway.
But direct-to-consumer care, I think, is a perfect model for chronic disease management, because especially for the middle class, because they want to know what is it going to cost me for this year taking care of my kid's asthma or diabetes. And we can say whatever it is, $150 a month, because you have a $5,000 deductible. Now they know it's $1,500 that they're going to have to spend out of pocket. But there's not this fear of, oh God, I got to go see the endocrinologist. It's going to be $400. And she tells me to come back in 2 weeks. It's going to be another $400. And if I have to come back to another, then my credit card's maxed out. How do I feed the kids? So that, I think, is the beauty of it. And you take the insurance company out of the middle, which all they're doing is taking most of the money and leaving the patient and the clinicians without any. That's basically the model in endocrinology and pediatrics, because they're so focused on these the $170,000 surgery should be managed by the insurance company. They should get the discounts. They should try to do it the best they can. There's a lot of money to be saved there. When you put these high deductibles and you limit access to people that need access, then they cannot have good outcomes. And when you make the doctor see 6 patients an hour or 4 patients an hour, especially in endocrinology, you cannot have good outcomes. Yes. It's not possible. It's not possible. Or psychiatry, it's not possible. Or pediatrics, it's not possible. The pendulum swings. You may get to the point where the people revolt. And they're like, we're not doing this anymore. We want better. So anyhow, this has been a great hour.
Thank you very much.
Thank you for your time. I love what you're doing. I love what you're doing. I think this is the future of medicine.
Yeah.
Okay, great. Thank you so much. Thank you for the vote of confidence. Because sometimes I feel like, what am I doing? Is this the right thing to do? But I think improving outcomes and physician and patient satisfaction, I think, is very important. So the people who find the value in it, physicians and patients, will be doing more of it, I will say.
I'm gonna leave the show with my usual line, Herb. Do good quality medicine and the money will follow.
Yeah, but I'm going to say something different, which is I'm a big fan of, and I know Steve Jobs had many warts, but I'm a big fan of him. And I think for anybody that's early to market like you are, innovative, with something that, as you said, is useful to the physician and useful to the patient, will struggle at first, but we'll find great success at the end.
Yep.
And so this is just part of the journey. You're an innovator and a disruptor. And so in the beginning, that entails much work and some failure. But in the long run, I think you're right on the right track. And I see you being extremely successful, and I'm rooting for you.
Thank you so much. I appreciate that so much. Thank you.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.